So we know that we started in the year 2000.
Discussions. So the topic that I'm going to discuss today is clinical assessment and prescription writing, redefining the approach. So a very warm good evening to all the participants, all the doctors who are there here today. And I thank the organizers for having me here to deliver this class. So we'll go in an interactive mode where you can you can put in the chat box the discussions. Then we can break the what you call monotony of a what you call one-sided lecture. So please write a prescription for a male aged 36 presented with pain in the lower back since 3 months. The diagnosis is made as Kadi Shula, or the modern diagnosis intervertebral disc prolapse L3, L4, L5. So please write a prescription for this. Either you can put in the chat box or you can unmute and you can ask. You can unmute and answer as well.
Participants, I have made the unmute button available for you. So you can unmute yourself and speak, or else you can put it in the chat box as our speaker had said.
I hope all of you are accomplished practitioners. So you might be dealing with such cases on a daily basis. So when you get a patient with low backache in 3 months, and the diagnosis, modern diagnosis, intervertebral disc prolapse. So please tell me what prescriptions you will give. Excuse me.
Sir, we have an answer in the chat box.
Sallaki tabs and Rashtra Sapta Kashaya. Okay. Can you please tell me why you selected these drugs and you may please unmute and you can share your opinion or you can put in the chat box.
Dr. Kanita?
Yes, ma'am.
Yes, you can answer.
And could you please tell me the rationale?
Sir, pain.
Okay.
And it is maybe due to sciatica, so.
Okay. So the selection of drugs is based on the patient's condition is sciatica. That is why we have prescribed the Rashtra Saptaga and the Sallaki. Okay. Any other prescriptions? Let us see 2 or 3 prescriptions more, then we'll go to the next slide.
Participants, you can write it in the chat box.
Please don't consider this as a viva. This is a particular one-on-one discussion between practitioners. I cannot say that any single prescription is wrong, is it? In Ayurveda, you can have your own opinion, your own yukti, and you can treat. So every prescription will be right in its own sense. So this is not like something judging your prescription capacity, nothing like that. We just want an active discussion, that's all. So please come forward and give me 2 or 3 more prescriptions.
Yes, please participants, without any hesitation, you can do. Okay, no issues. You are welcome.
Yogaraja Gugulu and Abhayarishta, okay. Dr. Nalini, could you please tell me why you selected these drugs?
Yogaraj Google for pain relieving.
Okay. And Abhayarishta?
Vatanuloma.
Vatanuloma, okay, very good. Yeah. Any other prescriptions? Okay, I will give you another case. Maybe you are fed up with treating back pain, so this is another case. A 40 years old female presented with pain and swelling in multiple joints, occasional fever since 2 years. RA factor is positive, and recently done ESR is 45 mm. So kindly prescribe.
Sir, Amavatari Rasa.
Okay, then
And we can do Svedana, sir.
Swedana. Okay, why Amavatari Rasa?
RA factor is positive, no, sir.
Okay, so
And
RF
ESR
is
is
positive,
also-
so Amavatari Rasa. Okay, so now my next question is this model of prescription right, or should we think about some other what do you call methods of assessment and prescription? So usually what we follow is something called as a pattern oriented method, where when we get a pattern of modern diagnosis or a pattern of modern what you call presentation in the patient, we select an Ayurvedic medicine. So a modern diagnosis A, somebody told RA and it is Amavada. So so we select a particular medicine that is Amavada Rirasa. There is another pattern that we usually follow is Ayurvedic diagnosis X is equal to Ayurvedic medicine Y. For example, Ayurvedic diagnosis Vadarakta is equal to Manjishtadi Kashaya. So this is what we have been trained upon and what is imprinted in our mind. I am going to tell a different approach today because I also we were also, when we studied, we were also trained by most of the teachers in such a way, and at least 2 or 3 of the teachers had a different opinion, and they actually lit our minds up. So we are having a different approach now, and we are getting very good results in the practice as well. So the question is, we are blindly following the modern pathway where in modern they have a specific disease is equal to specific set of medicines, but they don't take into consideration the patient factors. For example, what type of body or the prakriti the patient has. It's a lot of things. But now the modern medicine has started identifying lacunae in their approach. So they also now feel that there is a need for personalized medicine. So they are also behind personalized medicine now. So let us see how we can tune our approach. So the first question is whether the Ayurvedic diagnosis is only about naming the disease. Can I have any input? If yes, you can put Y in the chat box. If no, you can put no in the N in the chat box. Is just Ayurvedic diagnosis just about naming a disease? If you support it's okay, then you put Y in the chat box. And if it is no, then you put N in the chat box. I got 1 N. Okay, 2 N's. Okay, so can you please tell me how it should be? Some of you who have put N, can you please unmute and tell me how it should be?
So there are many rogas which are not named by our.
Okay. So even in the named disease, is what do you call the name enough for prescribing? That is my question. Suppose, for example, Vadarakta is there in our textbook, and there are a lot of medicines told. So you write Vadarakta. Is that name enough to prescribe?
No, sir.
Then what all things we need?
We have to assess the Prakriti and.
Okay. So all these things, see what I am telling is all these things, the technicalities we will always tell and we will always write in exams. But in real practice, are we doing that?
Hello, sir.
Yes, please.
Sir, it's not related to name because whenever we get the patient, each patient is different and their hetus are also different. So according to that, first we have to take the hetu. Then first we have to take which complaints they are telling. According to that, we have to select which one is more vata, pitta, kapha, like that. Then next we have to select the dusha and which dusha is affected. Then next it is Avrodhajanya or pure Vata. Then last, which is Pradhana dosha. According to that, and Anubandha dosha. According to that, we have to select the medicine, because nowadays our granthas are mentioned so many diseases, but nowadays so many diseases are which are anukta vadis, so it will help us to make a diagnosis.
Yeah. You are right. So that's why this pattern oriented method where sciatica is equal to Yogaraja, such type of approach may not be beneficial always. If you write such prescriptions in 100 patients, some 30% of them will get good results, and other 70% may not get proper results. So how we can approach this in a different angle? That's what we are going to discuss. So all these logas you might be knowing: Vigaranama, Kushalona, Jihriyat, Kadajana, etc. So what Charaka in short he says is, we have to look at the Vigara Prakriti, what type of Vigara it is, and Adhishtana and other factors related to the disease. And Samuthana, that is a Nidan, as she rightly told. I don't know the doctor's name. Could you please tell me your name, please? Just now you.
Dr. Ujjwala sir from Bangalore.
Okay, Dr. Ujjwala. Yes, you rightly said it. So that the specificity of Nidana is very important in prescribing. I will give you so many clinical examples throughout my session now. So this sloga is very, very important. Tasmat Vigara Prakriti Adhishtana Antaranija Samuthana Visheshansha Buddha Karma Samaja. So that's why Chakrapani says that Jwara, Rakta Pitta, etc. Only the naming is not that much important. Adhishtana Antarani, Asya Antarani, etc. So we have to see how this disease process was initiated in a patient's body, in what substrate this disease is happening, and what are the characteristic features of the disease. Then only we can start prescribing the medicines. So that's again, somebody told now itself that there are a lot of diseases that are emerging, new diseases emerging, for which we don't find quite or exact equivalence in our science. But still we can treat. That is what Susura says, Nasti rogo vina dosher, yasmat tasmat vijakshana, anuktam abhidoshana, linger vyadhi ubhajaret. So you might be thinking I am telling a lot of slogas and this class will be boring. No, it's not. It will not be boring. The slogas will end here. Now, from now onwards, we will only start discussing clinical application of our principles. So what is special about Ayurvedic approach? We usually boast about that there is something unique about Ayurvedic approach, and we tell a lot of these things: Dusham, Desham, Balam, Kalam, etc. But ultimately, while we prescribe, we end up doing the same thing. Okay, psoriasis is equal to Mahamanjishtadi Kashaya, or gout is equal to Manjishtadi Kashaya, like that. But that will not be effective in a routine clinical practice. So Ayurvedic approach is always about dynamic assessment of the disease. So the Roga Avastha changes through the course of the illness, and based on the Roga Avastha, we may have to modify our prescription. So the assessment of the disease is always dynamic, and the diagnosis or the clinical method is not about identifying the name for a disease, but the diagnostic assessment is all about identifying the various therapeutic indicators in the patient, so that we can personalize the treatment and medicines in the given patient. That's the important thing, and so that we should be able to tailor the treatment for each individual. And also, rather than prescribing one medicine and asking the patient to take these medicines for months along, we should be able, or we should equip ourselves to monitor the progress and modify the treatment at appropriate time intervals. That is again very important. So Ayurvedic treatment is not like a disease A is equal to a drug A. That is not the case. So before going into the Ayurvedic diagnostic approach, let us see what are the diagnostic models in modern medicine. So basically in modern medicine, there are two types of diagnostic models. One is called as the intuitive approach or intuitive model, and the other one is an analytical model. So intuitive model is just like you see a patient with psoriasis, that pattern is imprinted into your mind. So next time when you see that pattern, immediately, without any thought process, you can identify that as psoriasis. So that rationality is bounded, it's very limited. And it's heuristic, so that it always depends upon your observational skills. And it is always about pattern recognition. You identify that pattern and you diagnose the disease. There is not much thinking into that process. So it is just like an unconscious thinking. But modern medicine, it's not like, analytical model is not like that. It's something called as a hypothetical deductive model, where you have to deduce the things from the available evidences. So you should apply the concept of reasoning in that process. So there is an unbounded rationality, and you have to apply your reasoning skills. So this is the best model. I will tell you an example. Suppose you went for a picnic, and you are going to a mountain top. So there are two ways in which you can reach the mountain top. One is you can climb through all the pathways so that you will not miss any plants, trees, or any sceneries in between. Or else you can take a helicopter and directly jump onto the top of the mountain. So in that scenario, the second scenario, you will miss all the sceneries in between. But if you go through this process properly, then you will not miss any sceneries. This is the same way about diagnosis. But what happens is usually we go with this intuitive model. So most of the times we end up in a failure in assessing the disease. But when we come to Ayurvedic diagnostic models, we know these are the diagnostic models: Pratyaksha, Anumana, Yukti, etc. Usually what happens is we will apply all of these simultaneously in a patient, so that we cannot stratify or separate them from each of these things, because simultaneously we will get a Pratyaksha and we will apply Anumana and Yukti and all these things. But if you want to segregate that and analyze, then Pratyaksha is something like pattern recognition method. Anumana is deductive reasoning, and Yukti is again deductive reasoning based on multiple factors, and Upamana is just like pattern recognition, where just like an example, Kraustuva Shirsha, you see one Kraustuva Shirsha, then next time you get Kraustuva Shirsha, you will identify accordingly. So that is something like analogy. And Arthopdesa is mandatory for all these things, because what mind doesn't know, eyes cannot see. There is an aphorism in clinical medicine: if you don't know the theoretical knowledge of something, even if the patient comes to you with a particular condition and sits in front of you, you will not be able to identify, because you are not knowing that. So Arthopdesa is again very important. In the current context, we can consider Arthopdesa as our textual knowledge. So we discussed about therapeutic indicators in the patient. So what are the therapeutic indicators? So the first one is a disease workup. So we have to concentrate about the roga. So there, as somebody told earlier, we have to assess the dosha, roga marga which is affected, and the bala of the roga. So bala of the roga can be identified with the help of available nidanas in the patient, Purarupa, Rupa, and Ubadravas. Then also we have to assess the avastha, Sama, Nirama, Uttana, Gambhira, etc. avasthas. Next is the Rogi Pariksha. So even though for the ease of understanding we are discussing this separately, that doesn't mean we have to do it separately. In a routine clinical practice, all these things happen simultaneously. So we are not doing, okay, you come and sit here, let me first assess the roga, and afterwards then, okay, now let me assess the rogi. It's not like that. This process will go simultaneously, but for the ease of discussion, I am segregating it separately. So in case of patient workup or the Rogi Pariksha, we have to assess. Predominantly, we have the Dashavita Pariksha, but at least these factors are to be assessed. That is the Prakriti, the Satmya, the Sattva, the Bala of the Rogi. So here it was the Bala of the Roga. Now here it is the Rogi Bala. So that includes the Vaya, Sara, Sampanana, Pramana, Vyayama Shakti, Agni of the individual, etc. Then there are some extrinsic factors which is outside the patient's body. So that includes Kala, Desha, etc. If you take the Kerala textbook Chikitsa Manjari and you take Jwara Chikitsa, the first chapter, the first sloka itself says that you have to analyze the Kala before you start treating, because now it's summer, you give Ushna medicines in summer season, there are bound to be some problem in the patient's body. So if at all Ushna medicines are indicated, you may have to do necessary modulations before administering the medicine. So these are some of the extrinsic factors. So these indicators are mandatory to prescribe in Ayurveda. So let us see how we can go about this. So first let us see the Roga Pariksha. So even though I am telling it this in sequence, you can always do this simultaneously. I am not telling that you have to stick into this sequence, but this sequence I have made for the ease of discussion. So in that, first thing that we will do is we will collect the signs and symptoms available in the patient. So Lakshana Sangraha. And next we will analyze. So we'll apply reasoning and identify which is the predominant dosha available in the patient. The next, we'll identify the dosha. Next, we'll identify the roga marga or srodhas. Then we'll also do some targeted questioning to identify the nidana in the patient. And then we will analyze the samprapti. And then we'll ultimately diagnose the disease. And then we'll assess the roga avastha as well. So first let us see the Lakshana Sangraha, how to analyze Lakshanas in the patient. So before going to the Lakshanas, could some of you tell me how you do it in your practice so that I will get an idea. So how you assess Lakshanas in the patient? I mean, we have all these modern terminologies. So once you get all this, once you fill up the history part, next how we are going to interpret that in Ayurveda?
Hello.
Yeah, please. Yes.
Sir, means I have to tell if one patient comes, I have to tell like that history.
No need. Just I want to know how you interpret this.
If the patient comes with Shula, I will assess it is Vataj.
Okay.
But next I will, according to Hetu, I will decide it is Avrojanya or pure, means Dhatukshayjanya. If patient come with Daha, and if he has a pimples and it is very red and he has a Daha more and burning more, then it will be Pittaj.
Okay.
And if
So
it
I'll
is
ask you a question. I will ask you a simple question. Please don't consider this as an exam. A patient came to you with fever and diarrhea. So now you have Jora and Adhisara. Now, how will you decide what is the condition in the patient?
Actually, I have to check the Hetu, sir, first.
No. The question is, I am not going into the Hetu part. I'm just telling you, because in Ayurveda there is a big confusion because Lakshanas and Rogas, the terminology used is same. For example, you get Adhisara in Pitta Jwara and you get Jwara in Pitta Adhisara. So a patient came to you with Jwara and Adhisara. Now the question is how you will identify which is Lakshana and which is the main Vyadhi.
That is little confusing, sir. But Jwara will be Pittaja condition and Atisar according to what type of Mala Pravrutti he is getting. Like if he is getting sticky stool and it will be like Kafaj. If it is getting burning in a stool like that,
Okay. So assessing Lakshanas in the patient, the biggest confusion that comes into your mind is Acharya has used the same terminology for the Vyadhi as well as the Lakshanas. So how to do that? So symptom terminologies may represent either the Pratyatma Lakshana or an associated feature. For example, in case of Jwara, what happens is the patient has fever on most of the time of the day and patient got 3 to 4 loose stools. Then in such a scenario, Jwara is the main Vyadhi and Adhisara is an Anubandha Lakshana. But you think about another patient where the patient has around 12 to 13 episodes of loose stools in a day. And once or twice he got a mild fever. Then in such a scenario, Adhisara is the Vyadhi and Jwara is the Anubandha Lakshana. So this is only one small example that I told. Like that, there are a lot of confusions that can happen in our practice. So one thing that we can do is that to identify the Pratyatma Lakshana is that the complaint that made the patient to seek medical advice, the main complaint will be the Pratyatma Lakshana. But that will not be the case in every patient. So a clear-cut understanding is necessary. I'll give you another example. We get a lot of patients with a migraine headache or sinus headaches. And when you take the history properly, you will come to know at least 60% of the patients will have Amla-Pitta associated with that. So here we have the reference of Shirashula in Amla-Pitta. So once you start treating the Amla-Pitta, then the headache will go away. But most of the times, 90% of the times, the Ayurvedic doctor will fail to identify because we are so much tuned with the modern approach. So Shirashula is equal to Vada is equal to Patyakshadatri, Patyakshadanga Kashaya, Shirashula Adi Vajrasa. In that line, we'll think. So we will not think about the subtle pathology that is going on in the patient's body. So this has to be changed. This approach has to be changed. And another example, another theoretical example that I can give is, we have Kasa in Rajeshma, and also we have Kshayaja Kasa. Then what is the difference? So there, in Madhavadana, in Madhugosha commentary, they clearly says that the Kasa in Rajeshma is only one of the symptoms. But in Kshayaja Kasa, Kasa is the main Vyadhi and Kshaya is Anubandha there. So you may ask, what is the difference? There is a difference because if Kasa has a main Vyadhi, then the main therapeutic choice will be different. If the Rajeshma is the main Vyadhi, again the therapeutic choice will be different. So this has to be clarified. For clarifying that, in Charaka Nidana he says, Jnanartham yani choktani, Vyadhi lingani sangrehe, Vyadhe este tadadvetu, lingani ishtani na amaya. So wherever I have used some terminologies to identify the Anubandha Lakshanas of a main Vyadhi, in such scenarios, you have to take it as a Lakshana, not as a Vyadhi. That is what Charaka says. So how to elicit Pratyatma Lakshana? So a Pratyatma Lakshana can be any of these things. It can be the most severe symptom in the patient, or most persistent symptom in the patient, most chronic symptom in the patient, or a widely distributed symptom. For example, in case of an erythrodermic psoriasis, where it's a widely distributed symptom. So in such a scenario, that skin lesion or the kushta itself is the main Vyadhi. Or it may be a symptom of diagnostic importance. For example, somebody told Virdrasi. So that typical gait itself is diagnostic of that. So these are only some of the important points. You can again think about multitude of ideas to identify a Pratyatma Lakshana. For example, Pandu. Pandutvena Ubalakshito Roga Pandu Roga. So without that Pandutva feature, you cannot say that it's a Pandu Roga. So that is the one approach that we can use to identify Pratyatma Lakshana. Then there will be some Lakshanas which can happen as a Pura Roga. For example, somebody told about the Kadi Shula. And if a patient came to you with the Kadi Shula and the patient says that occasionally I have radiating pain, then you should consider it as not as a main Vyadhi or main Lakshana, you should take it as a Pura Roga of Gridrasi. So in Vada Vyadhi again it's told, Avyaktam Lakshanam Tesham Pura Roga is told. So whenever some Vyadhi is going to manifest, if the Lakshanas appear as Avyakta, you should consider it as a Pura Roga. So in lot of scenarios, for example, in case of an eruptive fever, the fever on the first day may be a Pura Roga of an eruptive pathology that is going to happen in the next 2 to 3 days. So we should not be a failure in identifying that. So some patients will come in Pura Rogas and you should be very effective in identifying that. Another important example is Gulma. You might have got so many patients who come with chest pain and they might have undergone ECG evaluation, etc. And all might have come normal. So we know that upper GI pathologies can present as Hritshula. So there in Gulma, Hridaya is told as one of the Sthana of Gulma. And you just give Lashuna Kshirabhaga, the patient will become okay. So in such scenarios, you should be able to identify that this is something which is manifesting as Gulma or it's Pura Roga. So assessing Pura Roga is again very important. I will give you a video. So look at this patient. So this is something like a hemifacial spasm. So if you go through Suswa Samhita, he says, Yasyagrajo Lomaharsho Vedadur Netramavilam Vayu Urdham Tojiswava Todo Manya Anugraha. So this is told as Ardhita Pura Roga. So here we diagnosed it as Ardhita Pura Roga and we gave the treatment of Ardhita in this patient. And this is after the treatment. You can see the twitching has reduced markedly and there is only a mild twitching once in a while. So this is after 3 weeks of the treatment. So if you identify the patients early in the Pura Roga also, you can treat the patient and prevent the patient in ending up in a full-fledged disease. So that is about identifying the Lakshanas. So whenever you get a set of signs and symptoms, you should clarify in your mind, there should be a clarity in your mind, which is the main Lakshana or main Pratyatma Lakshana, in which spectrum of the disease this patient falls in, and what are all other Anubandha Lakshanas. Then once you get that Lakshana Sangraha, you will have the list of Lakshanas and you will have the chronology, which Lakshana got the patient which Lakshana presented first in the patient, and what are the other Lakshanas that developed during the course of the illness. And then you should identify the dosha vishesha. This is again another important thing. So somebody told pain is vada, but that may not be the case always. I have seen a lot of prescriptions where a patient with abdominal pain, especially in the Nabi region, that means the periumbilical region, and this pain happens in the afternoon hours, and this pain occurs in the mid part of the digestion, and people write Hingua Jadi Churna, and the patient gets the symptoms aggravated because they don't have the concept of Pitta Shula in their mind. So a prescription of Dhatri Loha might have given better result than the Hingua Jadi Churna. So the only thing is that you should be able to identify the dosha in the given patient. So pain is not always vada. What Ajay has told is a generic thing that whenever there is pain, there is vada. Even Shula Digara Ajay says vada is the predominant one. But to produce Shula, vada should be there. But who is the inciting dosha? Who is the initiating dosha? For example, a patient will tell you that I have abdominal pain immediately after food intake. Then you should not give any Vadahara measures. There you have to give Kafahara measures because immediately after the food intake, Kapha is the main dosha that is getting activated in the postop. We have studied Madhura Vibhaga, etc. So you give Kafahara medicines, then the patient will start getting the result. So how to identify the dosha? So the question is the common claims and comparisons. Are we right? For example, if there is inflammation, what is the dosha predominance? Can you please put in the chat box? Whenever there is inflammation, what is the dosha predominance? Okay. So I am getting the answers as Pitta. Okay. Now I will give you 3 questions and you have to give me answers. A patient came to you with arthritis. So the presentation is pain and deformity in the joint. What is the dosha predominance? Vada, Kapha, Vada. Okay. Another patient came to you with a rhinitis. So first day of rhinitis, the patient has the running nose, heaviness in the head, and sneezing. What is the dosha predominance? Kapha. Okay, I'm getting a lot of kapha. I will give you another question. A patient came to you with a cellulitis where there is reddish discoloration and fever to the patient. What is the dosha predominance? Now I am getting pitta. Okay, so my point is that there was a Hema Embar says inflammation can be any dosha predominance, and I agree to that opinion. So see, inflammation is not only pitta. It depends upon where it happens. Again, the dosha predominance depend upon in which stage of the inflammation you are seeing the patient. For example, even in the common cold, the first 2 to 3 days will be kapha predominant, then it will be pitta predominant. In the last stage, it will be vada predominant. You take a patient with meningitis, severe headache, it's vada predominant. So we cannot say always pitta is inflammation. That is wrong. This is one important thing that we have to identify is that whatever may be the modern diagnosis, the dosha assessment should be always clinical in the patient, in the clinical scenario. We cannot say always cellulitis is pitta. It's not possible because there are conditions where there may be vada association. There is that Aruna Varnada along with the cellulitis. So based upon that, we are supposed to prescribe our medicines. A patient with hypertension will come to you with a headache as a predominant manifestation. Another patient with hypertension will come to you as giddiness or Brahma as a predominant manifestation. And another patient with hypertension will come to you with heaviness of the head as a predominant manifestation. So in case of pain, you may diagnose Vada. In case of giddiness, you may diagnose Pitta Vada. And in case of heaviness, you may diagnose Kapha Vada. And the medicine will vary You cannot say that Ashtavarga Kashaya is for hypertension in every case. That's not the case. So the dosha assessment, such an approach is not at all ideal in an Ayurvedic scenario. So inflammation is pitta, edema is kapha. That's actually rubbish and wrong. That should not. That type of practice has to be discouraged. So for understanding this concept, let us take an analogy. Let us take an example from real life. So let us imagine a pumpkin. So is the class boring? Should I reduce the speed, or can I go forward? If I can go forward, you can put
Yes.
Y in the chat box.
You can go forward, sir.
Please put in the chat box. I want feedback from the participants. If I can go forward, if it is not boring, you put yes. Okay. Otherwise, what happens? People will go away from their phone or laptop. So I don't know whether they are there or not. Okay. So let us take the example of pumpkin. You look at this pumpkin. It's very tender. It's very green. If you weigh this, it will be very heavy. And if you poke it, some clear fluid will come out of it. Now take this pumpkin. It is yellowish in color. It will be sweet, and it will be somewhat lighter to when you compare this one. And let us look at this pumpkin. See, it is totally dried up. So this is the same pumpkin, but you see, you can see different dosha predominances. Here it is kapha, here it is pitta, here it is vata. And even we can substantiate our treatment concepts with this. For example, if you want to ripen the pumpkin early, what you will do? You will apply smoke or you will heat it. So Ushna is the chikitsa for kapha. If you want to preserve the pumpkin as such now, you will put in the refrigerator. Sida is the treatment for pitta. And if someone will give you a dry pumpkin and you ask you to eat, you cannot eat it as such. So you may have to dip it in ghee, or you may have to dip it in some oily substance or water. You have to make it drava and eat. So snigdha is the treatment for vada. So like this, you can take a lot of examples. I just use this to teach my students that to see dosha in everything. You cannot outrightly compare rheumatoid arthritis is equal to vata rakta or amavata. That's not correct. In some patients, rheumatoid arthritis may be amavata. In some patients, rheumatoid arthritis may be vata rakta. It always depends upon up to which dosha level the disease process has gone into, and what is the dosha predominance at the given point of time. So this we have to keep in mind. So let us see how modern science looks at the pumpkin's various stages. So pumpkin fruit gradually accumulates considerable amounts of dry matter, total soluble solids, total sugars. So this is what modern science says about the changes that happens to pumpkin. But am I audible? Somebody is told that my voice is not clear. Am I audible? Okay, it's clear. Okay. So this is what modern science says. But see how Ayurveda approaches this. We may approach it in terms of firmness. That means our panja indriya. So acceptable or not, whether it is soft or not, whether it is sweet, etc., etc. So the same phenomenon is looked upon by different sciences with a different epistemological approach in a different way. But the thing is that whenever we apply that concept, we should be very pure to our concept. We should not mix it with modern. So usually I tell my students that they have to open two shelves in their brain. One is for modern and one is for Ayurveda. And there should not be any pathways in between, because once there is a pathway between modern and Ayurvedic concepts, you are going to corrupt our concepts and corrupt our practice. So dosha assessment dosha assessment is very important, especially whenever we want to generate prescriptions. So I'll just give you an example of how we can assess dosha in Kushta, because it's very easy to show photographs. See, Parushya, Kharabhava, Shyavarunatvam. So all these things are features of Vata predominance in a Kushta. That doesn't mean that this will stay as such during the course of the illness. So that whenever you start applying the oil, this Parushya will go off and maybe the Pitta predominance will happen next. So then you may have to stop the oil and you may have to go for Nalpamara, Kashaya, Dhara, etc. So this concept should be there in our mind, that the dosha can vary between different individuals. The dosha can vary between different time points in the same individual based on his food habits, based on the seasons, So there are a lot of things that can happen during the course of illness. See, Rauksham, Shosha, thinning of the skin, Sankoja, contractures. So all these things indicates Vada predominance. You see Raga, Parisrava and Bhaga, all these things are Pitta predominance. So Kleda, Angapadana, all these things indicates Pitta predominance. You look at the Shveda Varnada, Styrium, Utsedam, elevated lesions, all these things indicates Kapha predominance. See again Sneha, Kleda, Jantu, Krimi, etc. indicates Kapha predominance. So this is how you identify dosha predominance. So whenever you identify the dosha, always as I told earlier in the example of Shula, look for initiating dosha. Who is the initiating factor? For example, we get a lot of patients with acidity. There are two possibilities. One is just from now onwards, you start asking the individuals about whether they have any arthritis or hemorrhoids, whether they have any abdominal distension. So whenever there is arthritis, there can be Abana Vaigunya, and this Abana can become Udavarta, and this upcoming Vada will take Pitta upwards. So in such scenario, a Pittahara medicine will not give relief, but a Vadanulomana and Arshohara treatment will give relief for the Amlavita. But this may not be the case in another individual where the Amlavita is triggered by the Pitta itself, where you will give Pittahara medicines and you will get result. So depending upon the Nidana and specific pathology that is going on in the patient, you look for the initiating dosha, you look for the modifying dosha. For example, Shula is Vada, but you see, I have told you already there is Kafaja Shula. So in such a scenario, Vata is mandatory for producing the Shula, but who is the modifying factor? Kapha is the modifying factor. So in such a scenario, you may have to give Kaphahara medicines. So for identifying the dosha, you can use so many strategies. For example, time of the day when the pain is more, timing with related to food habits, or seasonal variations in the manifestation, the body part affected. For example, even in Shula, Ajara says in the upper abdomen it is usually Pitta Kapha in nature. In the mid abdomen it is usually Pitta in nature, and the lower abdomen it is usually Vada Pitta in nature. So like that he has told. So this reference is from Susura Samhita. So like this you can look at the body part that is affected. For example, you got a patient with cervical spondylosis. I have seen a lot of Ayurvedic doctors, they immediately start applying oil on the neck. So this is very wrong because the Sthanika dosha is always Kapha. So you should always go for giving something Ruksha there, Ruksha Sweda, etc. there, before starting to apply oil. So what Susruta says, Vaksha Triga Skandagadam Vayu, Manyagadam Dada, Vamanam Handi, Nasyam Ja, Ruksha Swedam Ja Prayojita. So in Vaksha, Skanda and Manya, etc. Pradesha, even in Vadavyadi Chikilsa, he says about Kaphahara Chikilsa. So usually we tend to forget all these things. So the body part affected is again very, very important. And also you can take clues from Nana Atmaja Vigaras to identify which is the dosha predominance. And you can also do another approach. You can quantify the lakshanas. For example, if the patient told 10 Pitta lakshanas and 9 Vada lakshanas and 3 Kapha lakshanas, then you can identify it is a Pitta Vada predominant condition. So like that, you can look at the percentage of the lakshanas. And sometimes what happens, you may have to give weightage for one of the lakshanas. For example, a patient came to you with jwara, and 5 features are there for Kapha. But the predominant one is that there is irregularity in the onset and increase in temperature. So that irregularity itself indicates Vada. So you have to give extra marks for that Vada there. So sometimes you may have to give weightage for some of the troublesome lakshanas. Then after identifying these, then you should consider about Avarana or Samsarga, then Taratama of the lakshanas, Anshamsha of the lakshanas. For example, in case of Taratama Veda, if it is Pitta Kapha predominant, then it is Guluchadi Kashaya. So in Guluchadi, it is told Pitta Kapha Veda. If it is Kapha Pitta predominant, then Padola Adhigana. So there can be subtle changes in the prescriptions. So usually what happens is we will prescribe a lot of drugs. We will take too much time to treat a patient. And after some prolonged period, you will get a result. Because we are always going with the trial and error method. But instead of that, if you go for that Sukshma assessment, then the initial prescription itself will give you immense results. Suppose a patient came to you with a kushta and the kapha, there is pitta kapha predominance, then you give Guduchi Adhikashaya. But another patient says, I have more itching than burning sensation, then it is kapha pitta. You give Padola, they will get immediate result. So like this Taradama assessment is very, very important. Then you should also assess Amshamsha Kalpana. This is again very important in case of diseases like Vada Vyadhi. For example, if it is a Stamba Pradhana Vada Vyadhi, the Ruksha Sida Gunas are more predominant. Then you will select a Kaya Sega or Pirichil for that condition. But if it is a Shosha Pradhana Vada Vyadhi, the Legu Ruksha Amsha of Vada is predominant. Then you do Shashtika Sweda. We have seen in lot of Ayurvedic institutions what they will do. Whenever they get a Paksha Gada, they will admit the patient. Then they will start Ruksha Sweda. Then they will go for Pirichil. Then they will go for Shashtika Sweda. And they will discharge the patient, irrespective of what is going on in the patient. So this is actually irrational prescription. If you know that the spasticity is more, you will never go for a Shashtika Sweda because it is Dhardikrita. It causes more Dridatva. If flaccidity is more, then you can know it is Dosha Pradhana. Then you can go for Shashtika Sweda. But if Stamba is more, spasticity is more, then you will always opt for Kaya Sega. So such a minute assessment is very important whenever you start planning the treatment. Anything to discuss in these areas, or else we can go forward. If anything is there, you can please unmute and we can ask. Or if there are some contrary opinions, again, I am always willing for inputs from you as well. So if there are some conflicting opinions also, you can unmute and we can discuss. Okay, I think there is no... Are you all people there? Or...
Yes, sir. Yes.
Yes. Continue. Okay. So now see, during a timeline of a disease, during the course of the disease also, the doshavastha can vary. You look at this patient with bronchitis. In the first week, the patient in the first visit had cough, profuse yellow sputum and fever. Okay. So you can see that this is a pitta predominant stage. Now, what happened? The next is the patient in the second visit when the patient came. The patient had cough, chest pain, and thick and clear sputum and less appetite. So it is a kapha vada feature. Now, in the third stage of third visit, the patient had cough, dry and thin sputum. Again, it is vada predominant. So you cannot say you take Deshamula Kadatura Kashaya for months together. That's not possible because you can see even we are manipulators. We give medicines to manipulate the doshavastha in the patient's body. So this is what I told about everything about the dynamic assessment. Charaka even says that muhur muhuscha roganam avasthana madhurasya. So we have to repeatedly assess the patient. The doshavastha may vary repeatedly. So you have to modify your prescriptions accordingly as well. That's very, very important. So this is a case just to identify why this dosha predominance is very important. So this was a case of maturity onset diabetes of the young. So this is a male patient, a 24-year-old male patient. See, look at the fasting blood sugar; it's around 351. Okay, and the patient is not under any modern medicines, and he came to our Ayurveda college. So we did a we identified that it is a pitta vada pradhana prameha. And see, you look at the prescriptions. We initially gave a pittahara medicine in the form of tikta kashaya, etc. And then we targeted the medo dhatu with asanadikana, and the vada predominance we gave the Dhanvantara Grida. I don't think many of the Ayurvedic doctors will start prescribing Grida in a patient with a diabetes, but we assessed that it is a vada predominant one, and we started the Dhanvantara Grida. And you can see without any modern medicines, after a period of, so I think this is in May 2017, this is April 2018. You can see the blood sugar is totally normal within 1 year. It's not 1 year, the patient started improving within 3 months of the onset of the treatment. Just I wanted to show you the result after 1 year of the therapy. So this is the importance of. So here usually when we get the Prameha, what will be our usual prescription? Whenever we get diabetes, what will be our usual prescription? Can you please post in the chat box? Notwithstanding what I have told now. Yeah, Nisha Malagi. Then we write Chandraprabha, isn't it? So usually Katha Gadira, Nisha Katha Gadira, yes. But we didn't use any of these drugs in this patient because see, so that's what we have to assess the condition. We have to assess the dosha predominance in the given patient. Then we have to prescribe. This is another thing. Usually we get a lot of patients with hypothyroidism, and people will tend to write Kanchana Rogulu in every patient with hypothyroidism, thinking that it is goiter. But you look at this patient, where the Pitta Vada predominant presentation was there. The patient had full burning sensation, etc. And we gave Drakshadi Vada and Pitta Grida, and the patient became okay. The TSH, everything became normal. But the common prescription usually the people do is Varanadi Kashaya, Kanchana Rogulu. This is that modern mentality. Hypothyroidism is equal to Kanchana Rogulu and Varanadi Kashaya. So that should not be the case. This is another patient with hypothyroidism where the patient was exposed to Abhishanti Ahara like Dadi, etc. And the predominant presentation was Kapha Pitta Pradhana presentation. So then what we did is what we did here is we identified that this is Kapha Pitta predominant and we gave Kapha Pitta Hara treatment and the patient responded. We look at another condition where we suspected Avarana. So this is a patient with a cervical myelopathy. And the patient was quadriplegic when the patient came to our hospital. And this is what the patient was evaluated on a modern facility and they have diagnosed it as cervical myelopathy. So our indicators were that the patient had Madhumeha and Medak of Avarana, which resulted in Sarvangavada. So what we did is we went for Udvartana, etc. treatments and we gave Erandamula, the Yabanavasti for 15 days and following which we started the patient on Leshuna Rasayana. So after 1 month of the therapy, the patient went home in a wheelchair. And after 2 months, the patient started walking with the support. And now the patient walks without any support. You should remember that the patient was quadriplegic. So identifying, but we cannot say that every cervical myelopathy is Avarana. No. In the given patient, because of the evidences of Avarana was present in the given patient, we gave such a treatment. So we cannot generalize that in every cervical myelopathy, Leshuna Rasayana. That's not pure Ayurvedic approach. This is another case of quadriparesis. Again, this is also a condition of CIDP, chronic inflammatory demyelinating polyneuropathy. The patient was initially evaluated at the Thrissur Medical College. And there were sensory involvement. And again, we diagnosed it as Kapha Avarana. And the patient had Kapha Vada Pravritti. And even with a good Agni Bala. And again, the patient was treated with all those Shodhana therapies like Basti. And finally, the patient was put under Chitraga Rasayana. And after the Chitraga Rasayana, the motor symptoms completely resolved. The patient started walking on without any support. Only thing remained was sensory symptom for which the patient is still under our follow-up. But the thing is that here also we identified it as Avarana. We didn't give any Taila, Kaya Seka, etc. Or even Shastika Sveta, etc. Nothing was given in this patient. So that is regarding the dosha vishesha. Some of the finer aspects that we have to identify whenever we discuss the dosha vishesha. Hope I am not going very fast. If you want to slow me down, you can tell me. If you want to discuss anything regarding what we have seen now, you can unmute and discuss. Otherwise, we can go forward.
Sir, in Madhumeha also the doshavastas will change from time to time, sir.
Definitely.
Whether we need to change the treatment line.
Definitely, it will change. That is why I am telling a pattern-oriented method like in every Prameha, Nishamalagi or Katha Gadarati. There is a typical stage in which we have to prescribe Katha Gadarati. So that stage is very important. So we should identify what is the underlying pathogenic process that's going on. So the basic problem that happens to us is that we tend to identify the Samprati that is told in the textbook and we apply that in the patient. That should not be the way. We have to identify what is the Samprati in the given patient. So whatever Samprati is told in the textbook is only what you call to guide you to think to guide your thinking process.
Okay.
But in every given patient, we have to identify which is a Samprati that is going on.
Sir, and first prescription will be for how many days, sir? Means if
That's what. See, our therapy should be basically target oriented. So whenever we prescribe, there should be clear-cut target in our mind. What is our target with this prescription? For example, a patient came to me with features of Amlavitta and low back pain. So we know that almost all Shulahara Kashayas are very Ushna and Tikshna. So I cannot give that in the patient. So maybe initially I will give the patient a Guluchadi Kashaya and Avibhati Churna. So my target is that I will tell the patient, see, I am not prescribing for your pain now. For that, I will give you an oil for applying. But I have to correct your GIT first. So this is what my prescription is. And you come after 2 weeks or 3 weeks, depending upon the chronicity of the illness. So my target there is now the reduction in the pitta in the kosta. So after that, I will switch the medicine. So like this, for every prescription and for every external therapies, we should have clear-cut targets in our mind. And once we achieve that target, we have to alter the treatment. Sometimes what happens, even after giving the measure for 3 weeks, there will not be a change. Then also you have to switch because that medicine is not fit for the patient. So I think a prescription can go up to 2 or 3 weeks. Then you can switch the medicine.
Okay, sir. Thank you.
Sir, what is the relation of emotion factors in Madhumeha, sir? Does it affect on the sugar levels?
Definitely it will affect because emotional stress always increases the glycemic level, the glucose level in the body. So there is a definite relation in that.
But in the treatment line?
In the treatment line, you have to give some Tikta Pradhana medicines which has action on Manas. Because for Manas, we have basically, you look at all the medicines that act on mind. Basically, they are either Madhura Pradhana or Tikta Pradhana. So in Prameha, you should go for Tikta Pradhana medicines.
Okay, sir. Thank you.
Somebody asked more about dosha avarana. Can you please unmute and ask what is your specific doubt about avarana? Dr. Neha, I think.
Yes, sir.
Please.
Sir, sometimes we confuse which dosas. How
So,
I can explain?
So basically what happens is avarana can happen to any dosha. If you look at the Udara Chikilsa Charaga, Chakravani commentary, even he says kapha over the pitta over the kapha, etc.
Yeah.
But clinically what happens is, avarana is only important for vada. So I will give you a scenario. You got a patient, a 60-year-old male patient who is obese and who underwent Sandarpana throughout his life, and he got a stroke, hemiplegia. And now, what might be the cause, whether avarana or dhatu-kshaya?
It may be dhatu-kshaya.
No, there is no possibility of dhatu-kshaya in a patient who underwent Sandarpana. Because the evidence itself says that the patient is obese, the patient is kapha-medo predominant, and the patient underwent Sandarpana throughout the lifetime. Definitely, there is no chance of dhatu-kshaya. That's what the people will tend to confuse. Hemorrhage, dhatu-kshaya. In fact, that is the rubbish, absurd. That's not like that. Even hemorrhage will present as avarana. So, only thing is that how we can diagnose avarana. There are only 3 possibilities. One is from the evidence from Nidana. What are the food habits of the patient for a long term? So like that from Nidana. Second thing is from the presentation, because 2 things are there. One is abrupt onset. The other one is fluctuations in the clinical manifestations. These 2 are characteristic features of avarana. Third thing is upachaya and upachaya. There are only 3 possibilities to identify avarana in a patient. One is evidence from the Nidana. The second one is the lakshanas. And the third one is upachaya and upachaya. Lot of people will tell Parkinson's is Kaphavruta Vyana. That's not true in every case. There have been a lot of Parkinson's case where I identified it as Dadukshaya and we gave Mamsarasa and the patient responded. There are Parkinson's patient where there is Kaphavruta Vyana and we gave Avarana Chikitsa and the patient responded. So that always the decision depends upon the given patient. In this patient, what's going on? So we cannot generalize that. So that is why Avarana diagnosis should always depend upon three factors: evidence from the patient's Nidana, evidence from the Lakshanas, and evidence from the Upasyanamshya.
Okay, sir.
So after giving Mrudu Virejana, patient still complains about constipation. So usually here two things can be tried. One is Abhyantara Snehana, or the other one is what you can do is go for Matravasti continuously for some days. Then the patient will get relief. Because this type of constipation happens due to Krura Koshta, that means Vada Prakopa in the Koshta. Okay, so that is regarding the dosha assessment. Now we'll go into the Dusha Vishesha. So how to identify the Dusha Vishesha? So there is a lot of possibilities. One is you can go from the direct references from Charaka Sutra 20th chapter, where each Dusha Lakshanas are told. Asaraddha, Aruji, Asi, Vairasyam, etc. for Rasa, Pushta, Visarpa, Pedaka, etc. for Rekta, like that. Indirect references can be found in case of respective Vyadis in the Chikitsa Adhikara and assumptions based on Upasya and Anupasya. And there are so many clinicians who say that we can also take inputs from the lab parameters to identify doshas. But personally, I don't support that. I usually rely on the lakshanas in the patient. For example, you take this ichthyosis. So usually ichthyosis, the people will start thinking in the line of Kushta, and they give a lot of Kushtahara medicines and the patient will not respond. Because here the culprit is Rasadhadu. The Rauksha is happening due to the Rasadhadu. You give Pandu Chikitsa, the patient will respond. It's not because I am telling this is Pandu, but the drugs told in Pandu are typically aimed at Rasa and Rakta. Hey, look at this. This is again Rasa and Rakta are involved. You can see the Pandutva here. You might have learned about the sloka Pandu Danda Nagoyastu. So this is typically a patient whose HB level was below 5. The patient needs better execution in such a case. You look at this here. There is the dusha is Rekta and Mamsa. You can see the sofa as well as the raga. So here it is Rekta and Mamsa. See here again it is Rekta. Dusha is Rekta. So like this. This is only in the case of skin manifestation I can show you images. But there are so many other situations where we cannot take images. In all those areas, you apply your common sense and you apply the principles that are told in the textbook to identify what is the involved dusha. Why I am telling this is because one modern disease can have different dusha involvement at different periods during the course of the illness. So that is why identifying this is very important. You look at this. This is a patient with what you call muscular dystrophy. You can see the distal muscles are wasted, but the proximal muscles are heavy. So here the dusha is Mamsa. Here you can see grandhis in different parts of the body. So here the dusha is Mamsa and Meda. You can see two conditions here. See, one is there are two pedagas. Here the difference is one is a Madhumeha Rogi and the other one is not Madhumeha Rogi. And Ajare has told, Vina Pramehe Piyade Jayande Dushta Medasa. Unless and until you treat the underlying Medo Dushti, you cannot treat such patients. For example, this patient had multiple courses of antibiotics and still this keeps on coming. And once we did give Medohara medicines, that means Meda Shuddhikara medicines, then the patient stopped having these recurrent abscesses. So identifying the underlying dusha is again very important in certain cases. You take it hypothyroidism because this is the most what you call confusing clinical scenario in our practice. Someone will call it Panduroga, someone will call it what you call Galaganda, a lot of things. But look at the clinical features. You observe the patients properly. What's going on? So here, hypothyroidism is basically Dhadu Gada Agnimandya. So once Rasadhadu is involved, the patient will present with fatigue, dry skin, anemia, etc. And next, when the disease starts entering into the Rakta Dhatu, then the patient will have cold intolerance, arterial rashes. Then when the patient starts getting the mamsa involved, then the patient will have muscle aches, weakness, cramps, and even slowly the neck swelling starts coming. Once the mamsa and medo gets affected, you can see a lot of hypothyroid patients without neck swelling. Why? Because the mamsa medo dhatu has not started involving that much. Once this gets involved, then the surgical removal, etc., will become mandatory. So when the meatus gets involved, then there is thyroid enlargement, weight gain, puffy face, etc. Even elevated cholesterols can happen in such patients. So the prescription will vary. For example, if RESA is involved, you just give Pandu Chikitsa, the patient will respond. Once Rekta is there, you may give Rekta medicines. Once Medas is there, then there is a role for Varanadi, Kanjana, Raugula, etc. So in the same way, once the Shukra is involved, the patient will end up in infertility. So you can see the sequential involvement of the Dhadus in a patient. So then the question arises, what is the difference between a Dhadu involvement and Dhadu Gadavastha? For example, you take disease like Pushta, you take disease like Jwara. Dhadu involvement is told as well as Dhadu Gadavastha is told separately. So how we can differentiate that? So let us take the example of a water tap and a clean water beaker. Now the water tap is normal, the clean water is coming into this system. Now here you see the water coming is very clear, but you are mixing mud in the water. So now this is the involvement of the Dhadu. So here the treatment is also somewhat easy because that we'll discuss later. You look at the third scenario. Even the water coming from the tap itself is very muddy. Here the water coming from the tap is very clear, but then the mud got mixed with that. But you take here it is the water that is coming from the tap itself is muddy. So here, this is the Dhadu involvement or Dhadu Dushti, where dosha has caused the Dhadu Dushti. So the treatment will be Shamana or Shodhana, depending upon the degree of involvement of the Dhadu. But here, it is Dhadu Gadavastha, because the formed Dhadu itself, the disease process has started playing in the formation of the Dhadu itself. Here, only the formed Dhadu is involved. But here, the disease process has entered such a deeper area so that the newly formed Dhadu itself is defective. So here is the role for Rasayana Chikitsas. Labhopayo hi Shastanam, Rasadinam Rasayanam. We have lot of Vyadhikara Rasayanas like Chitraga, Leshuna, Balladaga, Chilajadu, Gandhaga Rasayanas. Lot of things where the metabolic process in the Dhadu itself has to be corrected. So this is the difference between a Dhadu involvement and Dhadu Gadavastha. So this is very important clinically. So how we can identify? We can identify depending upon the severity of the Lakshanas, the overall nutritional status and Sahara of the individual, the chronicity of the disease. So with multiple parameters, you can identify whether the Dhadu is just involved or the disease has gone into a Dhadu Gadavastha. So again, the same thing I am telling. Here the Medo Dhadu is involved and we gave the simple treatment. But in this case, the Dhadu Gadavastha was there. So a repeated Shodhana measures and Rasayana measures was needed to correct this patient. I hope the concept is clear. We look at this thing. So this is a Dhadu Gadavastha. This is a case of Uttana Vadarakta where the Vrana never heals. So the disease process entered into the Dhadu Gadavastha. So in this patient, the indicators were Uttana Vadarakta with Vrana Upadrava, Pitta Pradhana Prakriti, Madhyama Bala and Sattva. See, this is the way we have to write our diagnosis in a case sheet. It's not just like you write the name Kadigraha and you start writing the prescription. Whenever you write the diagnostic parameters, especially in my college, for my students, I usually encourage them to write just all the therapeutic indicators. So Vada Pitta Adhika Vadarakta, Pitta Kapha Pradhana Vrana, Agni Mandya, and the patient also had Amla Pitta. So the treatment was initially correcting the Amla Pitta and Agni Mandya. Then the Vrana Chikitsa was given because the Upadrava Chikitsa was given first. Then the patient was subjected to Shodhana in the form of Virejana and even Rakta Moksha. Then Eshti Madhu Rasayana was given because here the Dhadu Gadavastha was there. So the patient will not get relief without giving any Rasayana protocol. So after the Rasayana, this is the result. You can see It has completely healed. There is nothing in sort of a what you call vrana in the patient's body. So this is the importance of identifying the dhatu gadavastha and giving the treatment. So that is regarding the dosha. So we have already finished the lakshana, the dosha vishesha, the dosha vishesha. If there is anything to be clarified here, you can unmute and ask. Otherwise, we can go forward.
Hello, sir.
Yes.
Before giving rasana, that shodhana should be needed, na, sir?
That is very important. If at all possible, if the patient's body, including the Sara, Agni and Bala, is allowing you to carry out Shodhana, then it is always better to do Shodhana and go for Rasayana. But there are some scenarios where the patient is very weak. So we just correct the Agni and start the Rasayana. There is no problem in doing that. But it may not give that much result when you give after a Shodhana.
Okay, sir. And my second question is, Jwara, they have mentioned Dhatu Pachak yogas.
Yes.
So it is necessary to give in all, means when we say Rasa Dushti, Rakta Dushti, we have to give that kashaya, or you have told if Rasa Dushti, you have to go to Pandu Chikitsa.
No, you can take in from everywhere. That is the beauty of Ayurveda, isn't it? You look at yogas like Kalyana Grada and all. It is told in Jwara, it is told in Visarappa, it is told in Kushta. The same yoga can be given. Why? Because Acharya have developed our pharmacology based on the dosha and dosha. So you can take medicines from either of these things. I am only telling that you don't call a disease Pandu without seeing Pandutva. But you can take a drug from Pandu and give in Jwara, no problem, provided the dosha and dosha that you are planning to hit is the same.
Okay, sir. Thank you so much.
Okay, can I go forward? So now next let us see the Roga Marga or Srodhas that is involved, how to identify. So whenever we ask the students to draw the Roga Margas, this is the picture that they usually draw. Yes or no? If it is yes, you put a Y, or if it is no, you put N in the chat box. Whenever we think about Koshta, Shaga, this is the picture that comes to our mind. This is the Koshta and these are the Shagas. One no and two Ys. Again, others can also post because we have 30 members in this group and I am getting responses from only selected 5 or 6 doctors. I think all others have kept their mobile open and doing something else, or are you concentrating in the class?
Participants, please respond.
See, you have to think that we are putting a lot of efforts in preparing all these slides, spending 2 hours in our busy schedule. So it will be very nice if you start interacting with us. We'll be very happy. Okay, this is the picture. So this picture is a flawed picture because this is something that came into our mind when we studied modern anatomy. That is the problem. Because you take the hand, all the srodhas are present in the hand. That means all the rasavahasrodhas, raktavahasrodhas, all are present in the hand. So this is the picture that will come. That's